For millions of adults, knee pain isn't just a nuisance. It's a barrier to independence, vitality, and long-term health. Welcome to the Aging Well podcast, where we explore the science, stories, and strategies behind living a longer, healthier, and more purposeful life. I am your host, Dr. Jeff Armstrong. I am joined by Dr. Tom Andriacchi, Emeritus Professor at Stanford University, and Jenny Erhart-Hledik, co-inventors of KneeMo, a groundbreaking wearable device developed from cutting-edge biomechanics research. KneeMo uses intelligent motion sensing and precisely timed vibration to reduce pain and improve muscle function, offering a promising alternative to drugs or surgery for those looking to stay active. We'll explore the science behind movement, pain modulation, and how this technology could help more people keep moving and keep aging well. Jenny and Tom, welcome to the Aging Well podcast. It's my pleasure to have you both on here to talk about your KneeMo product today and the science behind it. But let's just kind of first start by having you introduce yourselves and tell us a little bit about how you kind of came to doing this type of research.
So I'm a professor of mechanical engineering, a former professor, retired from Stanford, and so I'm now emeritus professor in mechanical engineering. But I've spent my whole career studying the mechanics of walking and how it affects the health of the body and specifically the health of the knee joint and hip joint and how painful knees experience walking changes that can impact the clinical outcome of a certain procedure. So published a couple hundred papers on the topic. So I feel I know a little bit about it right now. So Jenny is graduated from Stanford, and I'll let her now give a little background on what she does.
Yeah, so Tom and I originally met when I went to Stanford to do a PhD in his lab, actually. So I was very interested in biomechanical engineering, and Tom was a big name in that field. And I was actually really lucky. My PhD project was on a shoe for knee osteoarthritis, and it was a clinical trial. And so I got to see that whole evolution from an idea in the lab to a product that eventually was sold to the public. And so it was really great to see how something that comes out of research and understanding walking mechanics and how loading at the knee can impact joint disease can actually be taken just from an idea to a physical product. After I did my PhD, I stayed at Stanford for a lot of years doing research as an instructor and a research associate. And then eventually KneeMo, which has been a 10-year journey, our product, came out of that research. It became a startup company, and we finally eventually launched a product, which we're really excited about. But it was another one of those research concepts that then took many years to actually become a physical product that we had available.
Yeah, it's amazing how many years it takes for these great ideas to actually come to life. So
yes, more than you think and more than we want, I'm sure. But it does take a long time, and I think as academics, you can have great ideas, but it's a whole different process to then actually make that into a reality. And we've experienced all the ups and downs that came with that.
Yeah,
I always tell my students perseverance is a key to success. You know, if you think you have a good idea, stick with it, and it will come to fruition.
So what inspired the development of KneeMo, and how did the concept evolve from research to a real-world application?
Yeah, maybe I'll start with that question. As I mentioned, I have studied the walking mechanics of people with knee pain starting in the mid-1970s, so it goes back a ways. And I was able, because when I finished my PhD, I decided to take a postdoctoral fellowship, and I was embedded in an orthopedic department for, I thought it was going to be 3 years. I stayed there 20 years because the work was so fascinating. And what I found was that walking was a critical factor in the way orthopedic procedures, the success of orthopedic procedures came about. In particular, it was the mechanics of how the joint got loaded and how it moved that was important. And what that meant was that we needed a better understanding of walking mechanics related to clinical outcome. So, being in an orthopedic department, I had the facility of a laboratory where I could measure not just how it looked when people walked, but the forces that took place when people walked. Now, you can't see a force, so you need a laboratory to pick up that information. But I had it, and I could start studying patients early on that were being treated with various types of treatment, including medication, analgesics, and anti-inflammatories for osteoarthritis, joint injections, braces of a variety of types, and even total joint replacement. So I've studied all of those before and after the treatment. Certain things emerged out of that, and it took a while, to 20 to 50 years to find some of the things that came out of that. But one of them was that walking with pain, some people adapt to the pain one way and others adapt another way. And there was what we call a good adaptation to the pain and a not so good adaptation to the pain. And that meant that if we tested a patient, say, this year, and we followed that patient, say, for 6 years with a certain treatment for arthritis, if the patient had adapted a good walking pattern, and that meant using their quadriceps properly and kind of dynamically realigning the joint when they walk, they did quite well with a procedure for osteoarthritis. In fact, in many cases, patients that we followed with no treatment, but had the right walking pattern, the disease, if they had early stage osteoarthritis, it progressed slowly and they didn't need a joint replacement. The opposite happened for patients where the walking pattern wasn't quite what we had hoped for or they should have. And those patients progressed more rapidly or they didn't respond well to treatment. So the key was to identify those features of walking. There's a lot of things you can measure in walking, how the knee moves, the forces, the different, what are called moments that act at the joint, which is a mechanical equivalent of a force. And what we found was there were certain characteristics that were common to almost any condition that was associated with knee pain. And one of them was the inhibition to use the quadriceps muscle. And clinically, what happens in those patients is that muscle atrophies. And they develop a gait which is not good in the long term. And it's what we would call the stiff-kneed gait. And so during the support phase of walking, the knee would stay straighter than normal. And you can walk that way and use very little quadriceps muscle because the quadriceps muscle, which is the largest muscle on the front of the knee, is the one that would balance the knee when it flexed a little bit during weight bearing. So they didn't use that. They had a reduced range of motion as well. And there were a few other mechanical factors, but those were two that were striking. So then over the years, we kept saying, well, can we find a way to get those people to walk, better and walk in a way that helps them and reduces their pain? So we tried a lot of things. We tried the shoe, which actually worked pretty well, that Jenny mentioned. That realigns the knee. Like, for example, if a car is out of alignment, that shoe will help the dynamic alignment of the knee to straighten out. That worked okay, but it didn't really help too much with the quadriceps function, which is something else that we wanted to allow. So we tried some things like gait retraining and teaching them to walk slightly differently. That worked okay, but it required some compliance and a level of sticking with it, over after the training was over. That didn't last. So we said, well, we can we do something that you can just put on the knee and it does all the work. It does the thinking and it does it provides the stimulus to change the gait. And that's what led to KneeMo. The name KneeMo means knee in motion. So we don't call KneeMo a brace. We call it a mobilizer because it helps reduce pain while walking and it enhances quadriceps function. And we could pick that up, not just by asking people, did it feel better when you used it? Because there's this placebo effect that happens when you give any intervention. We did it in the laboratory where we're actually measuring directly quadriceps metrics that told us they were using their quadriceps. One of them was EMGs. And, and so based on that, and then we did a clinical study that was actually more rigorous, where we had a device that didn't provide the same activation as our device. And what I think now, I'm going to turn this over to Jenny, let her describe the clinical, because she was very involved in that study. So.
Yeah, maybe first I'll also just describe KneeMo a bit more. So KneeMo, it's a really slim design. So it's two motion sensing bands. You put one above your knee, you put one below your knee. As Tom said, we wanted to develop something when we were doing this that would do the thinking for you. So you didn't have to physically think like, okay, now I need to activate my quadriceps, because it can be difficult, right? For people to think that on every single step to remind themselves. And so KneeMo senses your motion as you're moving and then processes the data in real time through an algorithm so that it applies intermittent vibration that's synced to every step, for example, if you're walking. So it's turning on right before heel strike, turning off at mid stance, and then it'll catch your next step. So if you're speeding up or slowing down, or if you're jogging, cycling, it's going to adapt in real time to hit every step or every pedal stroke that you're doing. And as we were developing it as researchers, it was really important for us that we made sure that we had the clinical studies behind it. So we did first an initial study to show what happens just in a single time use. And so we looked at patients who have knee pain, but knee pain due to those conditions that we know reduce quadriceps. So ACL tears, unfortunately, even if you have it repaired, right, you're going to have reduced quadriceps function, meniscus injuries, and then knee osteoarthritis. So conditions that affect a large number of people. We had them wear KneeMo just in our motion capture lab, so the lab that's equipped to study how people walk in the lab, had them not wear KneeMo and did a test in the lab, and then they put it on. And we saw an immediate improvement in their quadriceps muscles function. So significant increase in our individuals, and those who had the worst quadriceps function at the start had the best improvement, which was great for us. And so 95% of people responded immediately in that single testing session. And then we went on and did a longitudinal randomized crossover study. So as Tom mentioned, we had them either wear KneeMo for 4 weeks or just off-the-shelf compression knee bands, the kind of that you buy off of Amazon, right, for knee pain. They wore both of them for 4 weeks and had a washout period of 2 weeks in between. And we saw with KneeMo significant improvements in pain when they were walking and also going up and down stairs. We didn't see it with the control device. And then also when wearing KneeMo, they had significant improvements again after wearing it for 4 weeks in their quadriceps muscle function, better activation going upstairs in quadriceps muscles. And then when they were going downstairs, better control of their movement, right? Better proprioception. So, after we did those studies, that's what really motivated us to say, like, okay, this really does work. It was a great idea, and we wanted to make sure it actually worked in the way that we wanted it to. And that's when, at that point, we said, okay, we have something here, and let's see if we can take this from the lab and a device that works great in the lab to something that'll work in everyone's life every single day, wherever they want to use it.
So a big part of this is the vibration pain relief. And I find that fascinating because I kind of stumbled onto that when I was teaching at Hope College and I had rotator cuff surgery. This is probably pushing almost 20 years ago. And kind of in my post-rehab, and I did all my own rehab, which my pre-physical therapy students are like, why are you not going to physical therapists? It's like, I'm teaching you. What do I need to pay somebody and have the inconvenience of going to a lab? But we had, our basketball team had been gifted with a whole body vibration platform, and the coach didn't know what to do with it. He kind of turned it over to me and said, hey, if you got some research you can do with it. And so I was just playing with it in a lot of different things. But what I would do prior to going into a lifting workout is I would just kind of hold my arm in varying positions and just let the vibration happen. And it actually deadened the pain. I can go in and lift without pain for that workout. So can you kind of explain for our listeners and our viewers a bit more of the biomechanical principles behind KneeMo's vibration-based pain relief?
Yeah, so Similar to what you said, so KneeMo uses a neurological principle called gate control theory of pain. So what that means is our body takes in inputs like vibration, but also pressure and temperature, and it senses those with larger, faster nerve fibers than the pain signals travel, which those travel along smaller, slower nerve fibers. So I like to, when I'm kind of explaining it, think of it as like a road where you suddenly kind of bring two roads together, and so the vibrations that is going faster is going to reach that section where they meet quicker than the pain signal. So if you can flood it with vibration, which feels good, KneeMo, it feels good when you're wearing it, the vibration feels nice, that signal is going to reach your brain faster than the pain signal and reduce some of the amount of pain that reaches your brain. And we know from research that when you have knee pain, you also have reduced quadriceps muscles function. There's research studies that induce pain and then show there's a reduction in quadriceps muscle function. So by doing that, that also allows people to better engage quadriceps when you do that. So it has a kind of dual mechanism there where you're reducing pain, which helps people while they're walking. And KneeMo does this while you're walking, right? You have to be moving to have the vibration activate, or running or cycling, whatever you want to do. And then at the same time, it allows you to better engage those muscles that are so important for joint stability and joint support, and also related to treatment outcomes and joint progression, disease progression of osteoarthritis.
So fascinating concept, and it's amazing that nobody came up with it sooner. So it was timely.
It only took us 10 years. It only took us 10 years.
Well, technically, it took you 50 years, you said, right?
Yeah, exactly.
Yeah, right. Yeah, because that it's kind of nuanced, but inside the device is a microprocessor that contains motion sensors, a Bluetooth communicator. It communicates with a smart device like an iPhone. So you can make settings that adjust to, say you're going to go jogging and moving faster. It'll set some of the metrics that control the sensing to set the vibration properly for whatever your activity is. Now, the sensor will detect the rate that you're moving, but sometimes we need to adjust the way it responds to that motion. And so the other nice thing that it does is it counts the number of steps you do or the number of movement cycles and how long you're using the device. So it gives feedback to the user. But we also are making it available to healthcare providers that are going to introduce it into their practice, and they can get an idea of the compliance of the patient. If if they give it to the patient to say, go walk, for an hour, do they really do that with the device? And it's interesting. I like to say it does all the work. You put it on, it feels good. And you walk better with it. And that's all you have to do. You don't have to learn any, feedback response to the device. The device works through something called the somatosensory system, which is the system that Jenny was describing. It describes the sensation of both mechanical stimuli applied to the skin as well as pain, the nerves that transmit pain. So when we did the clinical trial, we asked the patients to use the device for at least 1 hour per day when they go out for a walk. When we came back, and I don't think we told them we could detect how much they used it. And there were a few that didn't use it as much as they said. But the average usage, instead of 1 hour, was actually 3 hours because it felt good. And so one of the barriers that we had overcome with this device is compliance. I don't know if you've used some of these other bulky kinds of knee braces or things that you've probably seen them. Compliance is difficult because sometimes you got to strap it on, it's got to be tight, and it doesn't feel that good, and it looks bulky. This is a fairly sleek device that can be put on. Jenny, do you have the device with you there that you could show?
I was charging I use mine on every run, so I was actually charging mine. So it's currently in another room. but no, and I think, we've done the research. We've done research on braces. We've done research on a lot of different things, and that compliance is something that's always so difficult, right? Even with things like physical therapy, it's difficult because you have to rely on people being motivated to do either exercises at home or do the activity at home, or to consciously think. I've done a fair amount of work in gait retraining. It's difficult for people to think on every step that they're taking, like to how they want to change the way that their knee is moving or their foot is being placed on the ground. So really, when we set out to develop this, we were trying to take that component out so we wouldn't have to rely so much on people's will, I guess you want to call it, to do these things, but something that would be able to still give them a benefit without them having to consciously think about changing something with how they're moving. I think that's kind of, and we also wanted it to be, we're hearing from some people who are using it, like they've tried all the different braces, sometimes 2 at a time. And then if you actually want to go be active, restricts motion. So that's not ideal either, right? You want something that gives you support, but also doesn't hinder you from doing whatever the activity.